Good morning, and thank you very much. Thank you to Rob and the entire Critical Care Reviews committee for inviting us. This has been an incredible meeting for the last couple of days, and we're very excited to present the results of our trial. I'm Matt Prekker. I'm an emergency physician and intensivist in the United States, and on behalf of my colleague Matt Semler and our entire US-based pragmatic critical care research group, we're going to present the primary results of the direct versus video laryngoscope or device trial. We'll do this by I'll present the background and the rationale for our trial, and I'll come back and talk about the results. Dr. Semler will present the methods of the trial and then summarize our findings at the end. Our trial was funded by the US Department of Defense. By way of background, emergency tracheal intubation is a common procedure. It's performed over 1.5 million times in the ED and ICU in the US each year. Compared to other procedures performed by emergency physicians, anesthesiologists, or intensivists, this procedure carries quite a bit of risk. I try to illustrate that here. Considering the operating room setting in elective general anesthesia of surgical patients, the risk of a severe complication is around 2%. If that same procedure is done in the ED or ICU setting on an emergent basis, the risk of a serious complication could be as high as 40%. So that's a 20-fold increased risk that has to do likely with the patients that are critically ill, the clinicians performing the procedure, or other environmental or contextual factors. Failure on the first intubation attempt is a big deal. It occurs in 20 to 30% of tracheal intubations in the ED and ICU, and we look at this as really an opportunity for improvement, in that failure to intubate on the first attempt is associated with life-threatening complications. Illustrated here are 3 of those severe complications: hypoxemia, aspiration, and cardiac arrest. And you can see in the bar graph that the incidence of these severe complications is much higher when the first attempt fails. When I go to intubate a patient of mine, I have a choice to make right up front, and that's, do I use a direct laryngoscope or a video laryngoscope? These are the 2 most common devices used to perform tracheal intubation. A direct laryngoscope, it consists of a handle, a blade, and a light source. And the technique of direct laryngoscopy hasn't changed really in 70 years. In a supine patient, the laryngoscope blade is inserted into the mouth. It displaces the tongue and the epiglottis and allows the operator, the clinician performing the procedure, to have a direct inline view of the vocal cords through the mouth. A video laryngoscope has those same components, but is also equipped with a camera near the end of the laryngoscope blade, and that camera transmits images in real time to a video screen that the clinician views during the procedure. Video laryngoscopy, theoretically, may make intubation easier by allowing an operator to identify relevant anatomy and guide an endotracheal tube through the vocal cords without ever having to create that line of sight through the mouth to the glottis. These are data from the InTube study and presenting today at an international meeting. I think they're especially relevant. You can see that a direct laryngoscope is currently used for approximately 80% of intubations in the ED and ICU worldwide. And in fact, the only region of the world highlighted here that uses a direct laryngoscope on less than half of intubations is Australia and New Zealand. So are intubation practices supported by existing evidence and current guidelines? Well, tracheal intubation guidelines for critically ill adults state that either use of a video laryngoscope or a direct laryngoscope is acceptable. Interpreting the results of prior randomized trials in these settings is a little challenging for 3 reasons. The first is that single-center design is very common. In fact, we only have 1 multi-center randomized trial outside of the operating room comparing video and direct laryngoscopy. That's the MACMAN trial, which we'll talk about today. That was conducted in France in 7 French ICUs, and the randomization was to a McGrath video laryngoscope or a direct laryngoscope in the first attempt. And their result was neutral, similar rate of first pass success in both groups. The second caveat is that considering the entirety of previous trials, the sample size of these studies is relatively modest. The MACMAN trial, for example, enrolled 371 patients. Thirdly, clinicians, including those in the MACMAN trial, had limited prior experience with video laryngoscopy. We designed the device trial to address some of these issues. We designed a pragmatic, large, multi-center trial that enrolled in both the ED and the ICU, and and took advantage of operators that had a broad range of previous intubation experience. And so in doing the device trial, we hypothesized that use of a video laryngoscope will increase the incidence of first pass success. At this point, I'm going to turn it over to Matt Semler to present the methods of our trial.
The device trial was conducted by the Pragmatic Critical Care Research Group, which is a network of emergency medicine, anesthesiology, and critical care clinicians and researchers from 20 centers across the United States. And this network has completed 10 prior trials of emergency tracheal intubation. Device was designed as a parallel group randomized trial in 17 EDs and ICUs across the United States that enrolled all adults undergoing orotracheal intubation using a laryngoscope, except for those who were known to be pregnant or a prisoner, those for whom the emergent need for tracheal intubation precluded the performance of trial procedures like randomization, and those for whom the treating clinicians determined that either a video laryngoscope or a direct laryngoscope was required or was contraindicated for the optimal care of that patient. As a study that compared two standard of care treatments during an emergency procedure, the trial was conducted under waiver of informed consent, and then an IRB-approved information sheet was used to notify patients and families about their participation in the trial. Allocation was concealed until randomization using opaque envelopes containing trial group assignment that were stored with the emergency airway management equipment at each site. Patients were randomized in a 1-to-1 ratio to video laryngoscopy or direct laryngoscopy in permuted blocks of variable size stratified by trial site. Given the nature of the intervention, clinicians performing the procedure and research personnel collecting outcomes were aware of trial group assignment after randomization. For patients randomized to the video laryngoscopy group, operators were instructed to use a video laryngoscope on the first laryngoscopy attempt. And a video laryngoscope was defined as a laryngoscope with a camera and a video screen. And the trial protocol did not determine the brand of the video laryngoscope or the angle of the laryngoscope blade, which were determined by the treating clinicians. Treating clinicians were instructed by the trial to use the screen during the laryngoscopy and tracheal intubation procedure. For patients in the direct laryngoscope group, trial protocol instructed clinicians to use a direct laryngoscope, which was defined as a laryngoscope without a camera or a screen, and the trial protocol did not determine the brand of laryngoscope or the shape of the laryngoscope blade. All other treatment decisions about the tracheal intubation procedure were determined by treating clinicians. Prior to randomization, so prior to enrollment in the trial and randomization, the operator who is going to be performing the procedure made a subjective global assessment based on everything they knew about the patient about whether the tracheal intubation procedure would be easy, moderate, or difficult, and recorded that information prior to randomization. During the tracheal intubation procedure, an observer who is trained in the trial protocol and in the outcomes but was not involved in the performance of the intubation recorded the data required for the primary outcome, so recorded the number of insertions of the laryngoscope blade, the number of insertions of a bougie, if used, and the number of insertions of an endotracheal tube, in addition to recording the time of induction, the time of insertion of the laryngoscope blade into the mouth, and the time of tracheal intubation as confirmed by capnography. This independent observer also recorded information on the lowest oxygen saturation and the lowest blood pressure between induction of anesthesia and 2 minutes after completion of the procedure. Immediately after completion of the intubation procedure, the operator who had performed the procedure then recorded the view of the larynx during the procedure, the occurrence of aspiration, esophageal intubation, or injury to the teeth during the procedure, and then that operator's prior experience intubating. And so this is pretty detailed information that the operator reported on the number of prior intubations that operator had performed as of the time of that intubation, and what proportion of those intubations had been done with a video laryngoscope and what proportion had been done with a direct laryngoscope. So that information about the operator at the time of that procedure. Trial personnel then collected clinical outcomes from the electronic health record. The primary outcome of the trial was successful intubation on the first attempt, and this was defined as both a single insertion of a laryngoscope blade into the mouth and either a single insertion of an endotracheal tube into the mouth or a single insertion of a bougie into the mouth followed by a single insertion of an endotracheal tube into the mouth. So pretty precise and setting a pretty high bar compared to trials in which the laryngoscope attempts by itself were the definition. The secondary outcome was severe complications between induction and 2 minutes after intubation, defined as an oxygen saturation less than 80%, severe hypotension with a systolic blood pressure less than 65, new or increased vasopressor administration, cardiac arrest, or death. Assuming an incidence of the primary outcome of successful intubation on the first attempt in the direct laryngoscope group of 80%, a power of 90%, a two-sided alpha of 0.05, and less than 4% missing data for the primary outcome, we calculated that enrolling 2,000 patients would allow us to detect an absolute difference in the primary outcome of successful intubation on the first attempt between groups of 5%. So an absolute risk difference of 5%, which is the difference that was determined to be clinically meaningful in the design of prior emergency tracheal intubation trials. Our primary analysis was an unadjusted intention to treat comparison of the primary outcome of successful intubation on the first attempt between the trial groups using a chi-square test. The trial protocol specified a single planned interim analysis after enrollment of 1,000 patients and specified that at this interim analysis, the trial would stop for efficacy if the p-value was less than 0.001 for that comparison of the primary outcome between groups using a chi-square test. I'll walk through that slowly because that became relevant on November 17th, 2022. At the time of the single pre-specified interim analysis, the trial enrollment was stopped because the Data and Safety Monitoring Board found that the pre-specified stopping criterion for efficacy had been met. So to hear more about those results, I'm going to invite Matt Prekker back up to walk you through the results of the device trial.
Thank you, Matt. Let's take you through our consort diagram first. So in the 8-month period of time between March 2022, when the first device participant was enrolled, and November 2022, when the trial stopped at the interim analysis, 1,947 patients were assessed for eligibility. 73% of those were randomized into the trial. 488 patients were excluded. I'm going to magnify that to show you some more details. 373 patients were excluded because intubation happened too urgently to be able to complete trial procedures, namely randomization. 82 patients were excluded because the operator preferred a video laryngoscope or a direct laryngoscope, and I'll highlight that that's only 4% of all patients assessed for eligibility. And an additional 115 patients were excluded because they were eligible but not enrolled for the reasons I show here. Some more information about the patients randomized in the device trial. 707 patients were randomized to the video laryngoscope group, and 713 were randomized to the direct laryngoscope group. You remember that prisoners were excluded from the device trial, but in 3 cases, it wasn't recognized that the patient was a prisoner at the time of enrollment and randomization. That was discovered later. That was 2 patients in the video laryngoscope group and 1 patient in the direct laryngoscope group. Those patients were subsequently excluded from data analysis and collection, which left us with a total of 1,417 patients for our primary intention to treat analysis. I want to get into some data about these patients then. Overall, baseline patient characteristics were similar between groups. The median body mass index was 27. The indications for intubation, including altered mental status in 45% of patients, acute respiratory failure in 30%. Patients were intubated in the emergency department versus the ICU in 70% of cases. And then operators reported an anticipated difficulty of intubation prior to randomization of moderately difficult in 45% of cases and predicted difficult in 9%. How about characteristics of the operators? In the device trial, a total of 387 unique operators intubated during this trial. The median number of previous intubations operators in this trial was 50. And the proportion of prior intubations that these operators had performed with a video laryngoscope is shown next. About 60% of operators had similar experience with both a video and a direct laryngoscope. 90% of our operators were either an emergency medicine resident or a critical care fellow. Characteristics of the intubation procedure, we can say clearly that pre-oxygenation was performed in some fashion in nearly all patients. A sedative drug and a neuromuscular blocker were administered essentially to everyone except for the 5% of patients that were intubated during cardiac arrest and cardiopulmonary resuscitation. Glenn Eastwood did a really nice job yesterday presenting the TAME trial, and he came to his separation between groups slide as far as the arterial carbon dioxide content, many of you remember, and identified that as his favorite slide in the whole presentation. So I want to channel that and let you know this is our trial group's favorite slide. We had excellent adherence to the randomization assignment. So every patient assigned to the video laryngoscope group received a video laryngoscope on the first attempt. 99% of patients in the direct laryngoscope group received a direct laryngoscope on the first attempt. This table provides some additional detail on these laryngoscopes used on the first attempt. In the direct laryngoscope group, 98% of patients were intubated with a Macintosh blade, 1% with a Miller. The most common video laryngoscope in our trial was the Storz CMAC with a standard geometry blade used in 60% of video laryngoscopy. And I'll highlight that the video laryngoscope used had a hyperangulated blade shape in about 14% of intubations. Like all prior trials in this space, we found that video laryngoscopy improves the grade of view, the quality of view on the first attempt. This is highlighted here. A grade 1 view of most or all of the vocal cords was attained in 76% of patients in the video laryngoscope group and only 45% in the direct laryngoscope group. This is fine, but as an emergency physician and intensivist, when I have a critically ill patient who's hypoxemic and I've just paralyzed them, I've just interrupted ventilation to perform my first attempt. I'm really happy when I can get a nice view of the cords, but what I really want to know is, does my video laryngoscope increase my chance of success on the first attempt? So that brings us to the primary outcome of the device trial, which I'll present now. This is successful intubation on the first attempt. To remind you, this is a very stringent definition where success had to be attained on the one laryngoscope insertion and one tube insertion in the mouth. This outcome was collected by independent observers in 1,417 patients over the course of our 8-month trial. What we found is that in the direct laryngoscope group, first pass success happened in 70.8% of patients. In the video laryngoscope group, it was 85.1% of patients. This was an absolute risk difference of 14.3 percentage points, the confidence interval of 9.9 to 18.7, and a corresponding p-value less than 0.001. To put it another way, an effect size this big translates into when the use of a video laryngoscope versus a direct laryngoscope essentially cut in half the incidence of failure to intubate on the first attempt, from about 30% down to 15%. We think that's quite meaningful. Here we show data on the primary outcome as a cumulative incidence curve, highlighting that first pass success was higher in the video versus the direct laryngoscope group, and this is plotted relative to the seconds elapsed between insertion of the laryngoscope blade and successful intubation, so the duration of laryngoscopy essentially. Intubations happen more rapidly in the video group than they did in the direct group. We had pre-planned subgroup analyses of these 6 variables: the location in the hospital, the ED versus the ICU, the body mass index dichotomized at 30, whether traumatic injury was present, and anticipated difficulty of intubation. And the thing I want to show here is just all of the point estimates for the primary outcome favored video laryngoscopy. I'm going to highlight 2 additional subgroups that have to do with operator experience. The operator's total number of previous intubations are shown here, and we found pretty clearly that operators with the least prior experience seem to benefit the most from use of a video laryngoscope. It's also notable here that our most experienced operators in the device trial, those who had intubated more than 100 times, still had a point estimate that favored video laryngoscopy, and that estimate of 6% was greater than the minimally clinically important difference we had set out to find in the entire trial. Looking at one more subgroup related to experience, we subgrouped on the proportion of previous intubations performed with a video laryngoscope. And the thing I want to highlight here is that even among operators that had used a direct laryngoscope for over 75% of their previous intubations, so people very familiar with direct laryngoscopy, still derive benefit from use of a video laryngoscope. Our secondary outcome was the composite of severe complications. And that composite occurred in 20.9% of patients in the direct laryngoscope group and 21.4% in the video laryngoscope group. The incidence of each severe complication were similar between groups. We collected exploratory procedural outcomes. Like I mentioned before, the duration of intubation was shorter in the video laryngoscope group, 38 seconds versus a median of 46 seconds. To make an apples-to-apples comparison with the outcome of prior intubation trials, we here show the successful intubation on the first laryngoscope blade insertion, so the traditional definition of first attempt success, which was attained in 90.3% of patients in the video group, compared with 77% of patients in the direct group. Interestingly, collecting reasons for failure on the first attempt, the first attempt failed because of an inadequate view of the vocal cords in many more patients relatively in the direct group compared to the video group, 17% versus 4%. But unlike prior trials, we found a similar failure rate for inability to pass an ET tube or bougie in both groups of around 7%. Here are our safety and exploratory clinical outcomes. Our 3 safety outcomes of aspiration, esophageal intubation, and injury to the teeth occurred in similar numbers in both groups and were infrequent overall. Our clinical outcomes of ICU and ventilator-free days and mortality also were generally similar between groups. I'm going to hand it back over to Matt Semler to summarize the device trial results.
So in summary, the device trial was a 1,417 patient randomized trial in 17 EDs and ICUs that found that the use of a video laryngoscope instead of a direct laryngoscope increased the primary outcome of successful intubation on the first attempt from 71% to 85%. And the reason we think these findings are important is that failure to intubate on the first attempt may result in life-threatening complications. And in current clinical care, at least globally, 80% of critically ill adults right now are intubated using a direct laryngoscope rather than a video laryngoscope. What does a 14.3% absolute risk difference translate to? So this is a number needed to treat a little bit less than 7. And so if you think about the next 7 ED or ICU patients that you go to intubate, there are 5 of them who probably can be intubated successfully on the first attempt with either a direct or a video laryngoscope. There's 1 patient who might not be able to be intubated on the first attempt with either a direct or a video laryngoscope, and there's 1 in 7 patients who can be intubated on the first attempt with a video laryngoscope who can't be intubated on the first attempt with a direct laryngoscope. Just quickly, before we turn it over to the editorial, 3 questions that I think a clinician might have when seeing these results, one of which is, how do these results apply to operators with more or with less experience intubating previously? So we'll start with the really novice operator, the person who's performed between 0 and 25 prior tracheal intubations. As we think about this group, I want to highlight Roger Lewis's comments from the first day of the conference, which I thought eloquently described the fact we instinctively default to thinking about the learning curve as something that people get over, and we want to think about the experts. But when you look at tracheal intubation in any training center in the United States, in the far forward military settings that our Department of Defense trial funder, Department of Defense funder for this trial, all of the intubations in those settings 10 years ago, now, and 10 years from now are performed by people who are on the early part of the learning curve. And so that's not a transient state. That's where much of tracheal intubation in training centers, in pre-hospital settings, in military settings occurs and will always occur. So I think it was important to us to have these operators represented in the trial. And we found that the group this appeared to be the group for whom the benefit of video laryngoscopy was biggest. Obviously, this is a subgroup, and we should take it with a grain of salt. But in this subgroup, the use of a video laryngoscope rather than a direct laryngoscope appeared to decrease the risk of failure on the first attempt by about 25%, or a number needed to treat of about 4. What about moderately experienced operators, those with 100 to 250 tracheal intubations? In this group, the point estimate for the difference between video and direct laryngoscopy was about 6%, which is a little more than we set out to detect. And then what about the late career expert operator? So I think it's not clear how the results of our trial inform that population. And so I think in some ways this has an analogy to ultrasound guidance for central line placement, that if you're a very experienced operator who's performed thousands of procedures, that landmark guided central line or direct laryngoscopy may be a perfectly safe approach for you, but for many of the rest of us or in many other settings, using that visualization of an ultrasound or a video laryngoscope can help with the success of the procedure. The second question you might ask as a clinician looking at this is, well, if video laryngoscope use increased successful intubation on the first attempt, and successful intubation on the first attempt is associated with life-threatening complications, in this trial, why didn't use of a video laryngoscope prevent life-threatening complications? I think an important thing to think about in assessing that question is how much statistical power exists in this trial to compare the exposure of VL versus DL on the outcome of first-pass success, as opposed to the exposure of first-pass success on the outcome of complications. So with 1,417 patients in the trial, half of whom were randomized to and got a video laryngoscope, half were randomized to a direct laryngoscopy and got it. That's a lot of patients where those exposures are separated. And there were about 200 patients in the direct group and about 100 patients in the video group who experienced the outcome of failure to intubate on the first attempt. So there's a lot of statistical power there to look at that relationship between video laryngoscope use and intubation on the first attempt. And in contrast, when you look and see, if you are interested in failure on the first attempt as your exposure and complications as your outcome, it's only 200 patients who have a difference in that exposure, and there's only about 40 patients in that subset who have these severe complications. So the power to look at that second relationship between the surrogate outcome of successful intubation on the first attempt and severe complications is really limited here. And in fact, we would have had to look at the relationship between video and direct laryngoscopy and severe complications as defined in our trial. We would have had to have a trial that was about 7 times larger than this trial's final sample size. And then the final question, being transparent, what questions does our trial not answer? Our trial doesn't tell you which brand of video laryngoscope is better. It doesn't tell you which blade shape is better, hyperangulated versus standard geometry. I think it still is a really important question of how does the learning curve look for video versus direct laryngoscopy? Do those differ? And how do we best train learners in emergency tracheal intubation? Is direct laryngoscopy a core skill, or is video laryngoscopy a standard training approach? And then obviously our trial doesn't address any of the important questions in emergency tracheal intubation outside of laryngoscopy, like which induction medication results in the best patient-centered outcomes, which neuromuscular blocker results in the best patient-centered outcomes, which approach to pre-oxygenation prevents hypoxemia during the procedure, the role for high-flow nasal cannula to prevent hypoxemia, how do we prevent cardiovascular collapse, this host of other really pressing questions that are outside the scope of this trial. So I'd like to conclude that the device trial, our conclusion was among critically ill adults undergoing tracheal intubation in an ED or ICU, use of a video laryngoscope increased successful intubation on the first attempt compared to use of a direct laryngoscope. And we're really pleased that as of about this moment, this should be publicly available online in the New England Journal of Medicine. And we'd like to thank all of the patients and their families participating in the trial. the clinicians, the physicians, respiratory therapists, and nurses who actually conducted this trial in the process of clinical care, and then our research partners throughout Pragmatic Critical Care Research Group who devoted tremendous effort to this trial and are one of the reasons it's fun to come to work. So thank all of them, and thank you for your time.
Matthew, thank you very much, and congratulations on your publication this morning. I'd like now to invite Professor Eleanor Sullivan to deliver an editorial.
Thank you very much for inviting me to this meeting, and particularly to witness live the results of the device study, which we've all been eagerly waiting for. And we've just, because it is this whole topic of universal video laryngoscopy is a hotly debated topic. Tim Cook wrote this editorial recently, and to say it caused a storm was an understatement. So there are a lot of entrenched views on this topic still out there. So does this paper we've just heard move us forward from debating to making it a reality? So I'm just going to go back to NAP4. Now, NAP4 was in 2011, but it's still the most downloaded paper in the BJA in the last 100 years in airway management, because it was novel in that it was the first look in the whole country of all major complications of airway management in every hospital and in every department. So in that study, I think it opened our eyes to the problems of airway management in the critically ill, because the risk of an airway-related death or serious brain-damaged patient was at least 50 times higher in the ITU and ED compared with theatre, and that was new information for us, I think. And also, the incidence of unrecognised esophageal intubation, though rare, was so much higher in intensive care and in the emergency room. So we kind of called it unfinished business with regard to airway management in the critically ill, and this follow then we had DAS guidelines on this. But let's look at some of the studies on first pass success in critical older studies and put it in context. These studies were kind of the original ones. They didn't show improvement in first pass success. It was less than 80%. The more recent studies looked at VL versus DL, and you can see the MACMAN trial, which was mentioned already. That was in 7 centres, small number of patients, and showed a first pass success of only 67% with VL versus DL. Then some studies looked at the adjuncts. We know the importance of the adjuncts, bougies, stillets. And in fact, this group published a JAMA study looking at bougies versus stillets and found no difference in using a bougie or a stillet in first pass outcomes in a large number of patients. This study published in the last few days, or in the last few weeks, shows a difference in first pass success in trials in elective surgery. We're looking here at McGrath versus DL with a first pass success of 94% in big numbers versus 82% with a DL. So that's in surgery. But in the device study, as we've just seen, we've seen a first pass success, which is very much better than all the other studies, 85% in the VL group versus 70% in the DL group, which, and I think this is the take-home message, isn't it? And it is just a fantastic, positive RCT for change. The first pass success for trials in critically ill, I think we'd compare maybe the MACMAN directly with this because that's the most recent. Remember a pre-COVID study as well. And the MACMAN, as I said, was 7 centres in France and showing a very poor performance really in that VL, DL had both first pass successes of less than 70%. So how does this study add to the more recent publications on VL-DL debate? There's been a huge Cochrane review in 2017, followed by a bigger, they added more trials, RCTs to the review in 2022. There was the N-tube study in JAMA in 2021, and the sub-analysis of that in the BJA recently. So let's have a quick look at these. This is Jan Hansel, who was the main author in this. He added another 158 new studies, huge number of studies and huge number of patients, over 26,000 patients. And they looked at all hospitals and pre-hospital care settings and all levels of intubator experience in those studies. And what was the outcomes? Cochrane supports VL in adults as more effective than DL overall. And despite the heterogeneity of the studies, multiple outcome benefits were shown with large effect size. The sub-analysis, which was published again in the last few weeks in the Journal of Intensive Care Surgery, looked at 21 sub-studies, and VL was favoured in ICU and ED. So we're seeing a trend in all these latest studies towards an improved first success with VLs. Now, what about the in-tube study? Now, this wasn't an RCT, but it was a huge study conducted in 27 countries worldwide, looking at over 30,000 critically ill intubations. And adverse outcomes occurred, again, very high adverse outcomes in 45.2%, cardiovascular instability, hypoxemia, cardiac arrest. So adverse events, high incidence of those. But again, in the sub-study, overall VL use was low, 17%. But VL facilitated a higher first-pass success in 84% versus 79%. I say, again, higher first pass with VL. Now, the primary outcome in this study we've just heard was mentioned. So successful intubation on first attempt. And the definition is there, which you've already heard. And this is a surrogate for likelihood of complications, and is used in nearly all of these studies for the reasons that were articulated. However, maybe in future studies we should look at success at first attempt plus complications. And then, of course, obviously the numbers we have in these studies will have to increase. Now, the trial protocol in this study did not determine the brand of VL or the blade shape, which is selected by the operator. And VL was defined as a laryngoscope with a camera and a video screen. Now, those of us clinical know that these are all very different devices. The shape even of all the VLs, even the Mac-type VLs, is different, and they have subtle differences between the McGrath, the CMAC, and the GlideScope. And we must remember that the VL is a catchphrase for many devices, techniques, and they all have different limitations. So video laryngoscope used in this device was shown in the last presentation. So 76.3% used a Mac-shaped geometry VL, and 12.6% used a hyperangulated. But other VLs were not reported. 11% they didn't report which VL was used, and I don't think any channeled video laryngoscopes were used. But they said VL was at the choice of the operator. But in real life, I presume it depended on the availability of the device in the departments. And was there really a choice, or was it what was being used in that particular ED or intensive care unit? And the other point is about, which comes back to the studies on adjuncts. Getting a view is only part of the deal. You need to get the tube in, and when using VL, the curvature often results in the tip abutting the anterior tracheal wall. And this is the phrase we're using now, tracheal tube deployment. And from the very first studies, the GlideScope originally, that was the first point they made. You know, these, you can get lovely views, but can you get the tube in? And the device in this study, at all trials, a stiletto or bougie was routinely used during the first tracheal intubation. But randomly, I think, depending on which hospital or site the intubations were being done. But again, they're not a simple, the rigid stiletto is very different. The malleable stiletto with pros and cons. The bougies differ, and also some stilettos are matching to the tube. So again, this is an area for more exploration. Now, again, Driver and Prekker did, as I mentioned, a good study on this in 2022, showing similar first pass using a bougie and stiletto. So perhaps that's why in this study they gave the operator a choice in which they wanted to use for the intubation. Now, how difficult were the intubations? We know the intensive care ED intubations tend to be much more high risk for all the physiological reasons and other reasons. But the operator here performed a subjective global assessment of the anticipated difficulty of tracheal intubation. Was it easy, moderately difficult, or very difficult prior to randomization? And this was very subjective. And we know from work done by Audrey de Jong and her French colleagues that there's a very good validated score for identifying patients at risk for difficult intubation in the intensive care unit, the McCutcheon score. And that looks at factors related to the patient, for instance, Mallampati, cervical spine movement, etc. Factors related to pathology, like the Glasgow Coma Scale and whether the patient was hypoxemic. And the final one on operator experience, a non-anaesthetist, you got a slightly negative mark, whether that's right or not. But anyway, the positive predictive value of 3 or over implied a difficult intubation. So this is a very well validated approach, and I think perhaps should be used more. And we have put that into our critically ill guidelines, management of difficult area in critically ill patients, and use it. And I think it's quite a good one, and maybe for future studies that's something we should think about. We heard a bit about experience of the operator, and this is kind of a standout finding, I think, in this study. Operators had all performed, as we had, a median of 50 prior intubations. Also, they performed as many prior intubations using a VL as using a DL. And here is the graph of the operator number of previous intubations and first pass success. And you can see the learning curves for DL and VL are not parallel. And the magnitude of benefit for VL over DL is greatest for the inexperienced intubator, which we've heard. And the magnitude of this difference reduces as more experience is acquired. So if you have less than 25 intubations and you're handed a VL, you're going to perform better than if you're handed a DL. But over time, obviously, with the learning curves improving, that difference narrows. So differences in VL and DL outcomes narrows quite significantly with experience. I think this is a very important message from this study. Now, if we look back at the Cochrane review, though, of in 2017, they looked at experienced or inexperienced intubators. And they found that no difference in inexperienced users in reducing first failed tracheal intubation, but experienced users had a 3-fold reduction. So if you're using a VL in their study, they suggest, or in their review of the literature of the RCTs, you would only get the value of the VL if you're trained in it. So experienced users had there was a 3-fold reduction in failed tracheal intubation. So this study is different, but remember that was published in 2017, so perhaps the use prior to this of VL was much lower than DL. So that could explain that. So use of VL appeared to increase the likelihood of first pass success for operators at all levels, but the between group differences in the primary outcomes numerically greatest for the least experienced operator. And I think this is maybe the message, because if we've inexperienced people in these sites, should they be first handed a video laryngoscope? Probably the answer is yes. And why do we think that is the case? I mean, just exploring it. I mean, with a DL, you have a much more limited view. And this is a picture I got from George Kovacs, an emergency physician in Canada. And there, I think you'd all agree, that looks like the trachea, doesn't it? And would you be happy to put a tube in there? Anybody want to make a comment? But actually, if you use a VL on this patient, that's the view you get. You get a wider angle view. You can see, actually, there's no real arytenoids there, and I can't see the epiglottis. So George Kovacs has written about this, and it's a very, we call it kind of glottic impersonation. I think it's a very more common phenomenon than we realize. Also, we feel with a VL, you get a precision intubation. You have a wider view, and we now teach all our trainees that they have to see the epiglottis, they have to see the arytenoids, and then check when they've put the tube in that their arytenoids are posterior and epiglottis. So we're bringing the kind of intubation from me to we, as I think Fiona Kelly often says. And look, with the DL, it's just you, isn't it? Looking down there, your colleague or even your can't see, your assistant can't see what you're doing, and it really is a more limited view. So that could be the reason. Also, the reason for failure on the first intubation attempt with the direct laryngoscope was inadequate view with the DL in 17.3%. Inadequate view of the vocal cords, that's very high in this study. And Cormac Lehan in the DL group was 44.7%. Cormac Lehan 1, sorry, in the DL group was only 44.7% in the DL group. So very low Cormac Lehan's 1s compared to 76.3% in the VL group in the inexperienced operators. So I think it highlights the very poor DL skills. And again, this is 2023, and perhaps that's what's happening now. We have a cohort coming through who are very poor DL skills. So this is a picture I got from a colleague from an emerging department. Here the screen helps, doesn't it? The screen allows a second clinician to provide real-time feedback. And this patient, for instance, has cricoid pressure, which might be obstructing the airway. Cricoid pressure can make intubation more difficult if you're doing an RSI. And here the assistant can also see the view and can adjust the cricoid pressure. Also, if you have an experienced operator here, it can give some kind of advice. And this brings me to another point. The independent observer was presumably, we'll maybe discuss that, was it an anaesthetist or somebody with experience in intubation? Were they able to assist the people with the VL because they had the screen and they could see? Remember in this study, more people use CMAX with the big screen than they did McGrath's, which have the smaller screen. So perhaps, and in all these, in the study, there was always an independent observer available, but there was also a second physician in the room for all these intubations, 24 hours, which is a fantastic achievement. And one other point I'd like to raise is surprising data. Confirmation of tracheal tube intubation in the emergency department sites. There were only 3 waveform capnographs available, or 3 in 3 sites out of the 7 emergency departments. And in the ITU, only 2 of the 10 big ITU sites had waveform capnography. Now, it is a gold standard. It's been a gold standard for us since NAP4, because, again, esophageal intubation was a major problem in ITU and in the emergency department. So maybe something we can discuss, the lack of kind of waveform capnography, and it's something, I say, global capnography is becoming kind of a gold standard. So just finish now with what do the guidelines say. The DAS guidelines, which is the Difficult Society UK and Ireland, very widely, the first kind of simplified airway guidelines out there, say availability and scale in the use of VL, but it doesn't come down to, but you can use DL or VL as your first choice in tracheal intubation. The critical care guidelines, which came out again after NAP4, said use a DL, consider a VL if the McCutcheon score is 3+, if it's 3 or over. So they kind of have a kind of a relative contraindication. All the DAS guidelines, all the COVID guidelines, all over the world, you can look at them, they all suggest use VL as first line. And I think that's what's changed things, because we know now the higher percentage of intubators using VL. The Canadian Airway Focus Group did good guidelines in 2021, and they said VL, they were the first to come out with VL as first choice for all intubations. And then now this PUMA group, which is a group of anesthesiologists, intensivists, and emergency physicians from 4 continents in the world, with the aim of looking at developing universal guidelines for airway management that affect current consensus of all the major published international airway guidelines. So, and there's emergency physicians like John Sackles and George Kovacs on this and so forth, so that they would go across anesthesia, intensive care, and emergency medicine. And we've published one of our first papers from that group on preventing unrecognized esophageal intubation, because this has become a very hot topic in that there have been high-profile cases of unrecognized esophageal intubation that led to harm. So in that, these guidelines have been endorsed by all the difficult airway societies and by the Intensive Care Society and Emergency Medicine Group have supported them. And in fact, in the last few weeks, the ASA have given their support for the recommendations. And one of them is routine use of VL whenever feasible and work towards feasibility. In other words, in low middle income countries, work towards feasibility. And then another key recommendation is the operator is encouraged to verbalize the view obtained, and that comes with having the screen and being able to assist. So in summary, this study demonstrates that VL has advantages over DL, perhaps more in the ED, and to a lesser extent in the ITU by virtue of the numbers enrolled, and greatest for inexperienced operators, and relates to the different learning curves of DL versus VL, narrowing of benefit for those who acquired more experience. And just to conclude, it was an excellent study, well conducted, simple, pragmatic, multi-center RCT, and it addressed a very important question which we're still debating. Excellent data collection, etc., and I think handling with the independent observer was great. And a positive result which will change practice, which is fantastic. So to go back to my first question, does this paper move us forward from debating to making use of VL a reality? And I would say absolutely, and VL should be first choice for intubation in critically ill patients in ITU and emergency department. Thank you very much for your attention.
Thank you, Ellen. Team Matt, you have a a couple of minutes to address some of the points that Professor Sullivan has raised.
Sure. Thank you very much. That was an excellent editorial, and I'm so happy that you brought up so many of the points I hope the panel would discuss during the rest of our time. The couple things I wanted to address in response. Capnography first. I agree that this should be the standard of care in confirming endotracheal intubation. It has many advantages, and the PUMA group laid that out really nicely in your work. We're going to try to adopt those recommendations in our network, as we can. The independent observer in our device trial, at these sites, the sites could adopt whatever independent observer worked best for them. These people were healthcare professionals, but generally not clinicians. So at our site at Hennepin County, we used trained research assistants that were available 24/7 throughout our hospital to respond to an intubation in the ED or ICU and observe. They were trained and tested on their knowledge of the different components of the primary outcome, so I think it was quite robust. Other sites used a clinical pharmacist or a charge nurse in that role. Your picture you put up around intubating during COVID with someone behind a glass wall and all the clinicians in PPE brought back a lot of memories, but I think it highlights something, and that's that some years have passed between Cochrane reviews, the last clinical trials, and so one question that Matt and I in our network have thought a lot about is what changed? Why did we find this result in the ED and ICU? And the few thoughts we had were, I think there was an increased use of video laryngoscopy during COVID, that's for sure. And so maybe that changed the culture of the ED or the ICU to be more familiar with that technology. Our trial routinely used a stylet inside the ET tube or a bougie, and that's based on the nice data generated by the Stiletto trial. MacMan trial previously did not use either of those adjuncts. And then we were chatting just a minute before this about the role of supervision of relatively inexperienced operators by an experienced staff physician. And that was done routinely at the sites in the device trial. Always or nearly always, these intubators were supervised. And video laryngoscopy offers the opportunity to have the supervisor give real-time feedback, as you pointed out, to the operator performing the laryngoscopy. And then the last point I'll make before I give Matt a chance is around difficult intubation. We thought a lot about this, and I think to make the device trial as generalizable as I hope it is, we needed to enroll at least a proportion of patients that were anticipated or turned out to be difficult to make this a reliable trial. I think we did that pretty well. We tallied up the number of traditional difficult airway characteristics, anatomic characteristics of these airways, and at least one difficult airway characteristic was present in 50% of the patients in the device trial. 5% of the patients were receiving CPR at the time of intubation, and we had a very low exclusion rate compared to all the patients being intubated and screened for these trials. So I think that all reinforces generalizability.
Yes, so I'll just continue that one point, which is that for clinical reasons, identifying which intubation is going to be difficult is really important. And for trial design reasons, that's your baseline risk of the primary outcome here, right? And so this has two roles in this. And so we thought a lot about this, and particularly what objective scoring systems might we be able to capture in clinical care. So this is our 10th of these airway trials. And in a prior trial, the checkup trial, we collected that MACOCA score at all of the sites as part of the trial and evaluated its performance. And unlike the derivation and validation in French ICUs and a single derivation in the United States in an emergency department, we found that had no predictive performance. Part of that was that requires a patient to sit up and open their mouth to do the Mallampati score. It requires knowledge of their past medical history for sleep apnea. And as Prekker just mentioned, 5% of the patients who are intubating are receiving CPR in the emergency department, and you've never met them before. So I think that score didn't perform well in our settings, and so we didn't use it in the device trial. What we did use was this global assessment of just asking a clinician, the person who's going to do the intubation, looking at all the characteristics of that patient with your knowledge of whatever knowledge you have. Will this be easy, moderate, or difficult? And we weren't sure how that would perform, but I point out that that subgroup figure shows how it performed and actually did really well. That clinicians, when they identified a patient as a likely difficult intubation beforehand, those patients, the first pass success rate was like 50% in the direct laryngoscope group, that it really, I think, served that purpose in this trial. I think we want to think research-wise going forward how to get to a more structured assessment, but the MACOCA score definitely does not do it in our tracheal intubation settings.
Thank you, gentlemen. Time for some questions. Just before I take a question, I just wonder, how many people are actually using the Macoca or Macocha score as part of their clinical practice?
I don't do IT.
Okay, answers that. Okay, Paul, you have a question?
Thanks. Congratulations, great study. I just wanted to push a little bit further on the generalizability comments. This is still a relatively small number of sites in a single healthcare system. You talked about 80% of patients globally currently have used a direct method rather than video. Do you think the results potentially, and the editorial picked up on the working towards feasibility in low and middle income countries, do you think the results actually, I assume there isn't a huge amount of availability of the video method within low and middle income countries at the moment due to affordability, etc. Do you think these results will change that need, or because there wasn't a difference in complications, etc., will that work against that priority?
We could probably both give an answer to that. That's a great question, and I'm realizing there's an editorial and I've not seen it, so I look forward to reading that. So I think the question of generalizability in this instance for an anatomically focused procedure, there are some contextual factors that are not as big an issue as for other processes of care or other things. I do think the anatomic aspects of tracheal innovation probably are fairly comparable in an emergency department in Minnesota or Nashville or the UK or low and middle income countries. I think that anatomy and those considerations are probably constant, and there are always those training considerations, but I don't think there's any reason to think these results about that primary outcome are likely to differ. I think one question is how has the availability of this changed as the price of these devices comes down? And I think that was, we have no affiliations with any of these companies, but as people who administer an ICU, the certain of these devices are now within the range that is becoming affordable for even people to own. So I know people who own a video laryngoscope, not a health system. And so my hope would be, one, this applies because it's an anatomical question with a pretty direct answer. It's pretty generalizable. And two, that these devices are no longer cost prohibited in the way they were 10 years ago.
Kathy?
So I'd like to, well, first of all, I'd like to congratulate you guys. That was brilliant, Matt squared. And the rest of the team, obviously. So I want to pick up a little bit more on that. So obvious sort of implications of this is, the price drops, everybody use video, whatever they're called, and whatever. My concern then is the unintended consequence, which is there will be times when one isn't available, okay? So do you de-skill a whole future workforce? And, sod's law is I'll be that person where the power's off or whatever, yeah? And so it's just thinking that through. That's one thing. The second thing is, please don't give up on your subjective rating, okay? Because the subjective rating is, based on my experience, I'm anticipating this is a difficult one for me, if that makes sense. So you've got difficult per se, okay? So you can add up lots of, and I'm sure clinically you all add up the whatever it is score before you even start, because let's be honest, you've got loads of time where these poor people need a tube down their throat to help them breathe and whatever. So you're not using that score anyway, but it is very much, it's about it being difficult for me, which has an emphasis or a notion of your own ability in there. So I would vote for pragmatic subjective scoring. But yes, I'd be interested in the answer to the first one.
Yeah, thanks a lot for that question. I think it's really insightful because it brings up these questions about how do we train the next generation of airway managers, and what skills do you need to safely manage an airway, especially when you're using paralytics and taking a rapid sequence approach. I think it's not time to give up direct laryngoscopy skills, but I think video laryngoscopy, when it's available, is a really powerful tool to teach those mechanical skills of intubation. So the approach we take at Hennepin County, which we're not alone here, I know, is that we really prefer a standard geometry Macintosh-style video laryngoscope system, where in our early trainees learn to perform video laryngoscopy where they can identify the anatomy, and then as 25 or 50 intubations go by, we turn around the screen and force them to perform direct laryngoscopy under supervision, where each step and each half of the procedure is monitored. So that's the technique we take. The other point I'd make about it is direct laryngoscopy as a skill set is more than just the handle and the blade, right? There are associated and adjacent skills that are so important regardless of what equipment you're using. Properly positioning your patient, clearing the airway, having backups available, deciding when you're going to do awake endoscopic intubation. These are all the skills that we'll continue to teach regardless if we follow Tim Cook's or your or my advice to widely adopt video laryngoscope systems.
Another question.
Thank you very much. You said it was a great presentation, a great study. You said neuromuscular blockade. Do you have the details of which paralyzing agent you used? And was that equally matched between the two groups?
Yes, so the question was about which neuromuscular blocking drug. And so in both groups, and it was similar between groups, the majority of patients got rocuronium, and I think it was 60 or 70% rocuronium and 30% succinylcholine. And it's been interesting to watch that change over time. So when we first started doing this research a decade ago, it was the vast majority was succinylcholine. It's now every trial is more and more rocuronium, and there is a nice trial in JAMA on it. But I don't think we have definitive data, and so I think that to me is that variation in practice and that shift in practice without data for a neuromuscular blocking drug that can increase the risk of awareness during paralysis and potentially PTSD requires further study. So we're very attuned to that.
Thank you. And was the agents equally matched between the groups? Was it 70%
Yes,
in both
it's
groups?
identical in the two groups.
Thank you very much.
Can I just add to that? I think 4% had no relaxant was one point. And the second, you didn't mention cricoid pressure at all. And we have great evidence that it makes intubation more difficult in a high percentage of cases. So that wasn't included in the results I saw. Can you comment on that?
Yeah, we left those decisions around adjuncts to laryngoscopy and intubation really up to the local practice at the trial sites without specifying in the protocol. We didn't specifically record external laryngeal manipulation or cricoid pressure as part of the trial, but
I'll say that the reason we chose not to record it is we'd recorded it in all the prior trials, and it became so uncommon that we were just recording another data element for no reason that this has dropped out of practice for us.
That's very interesting because around the world there are places where it's 100%
Yeah.
used. So very interesting that in these sites it's not being used.
Right.
Yeah.
Another question at the back. Ewan?
Hi, good afternoon. Ewan Gallagher from Toronto. Congratulations to you both on a really terrific and exciting trial. I'm curious, should we consider this endpoint as a patient-important outcome? Because if you look at the kind of typical ICU trial outcomes that you measured, we don't see a big difference. And of course, we want to be successful in the first pass attempt, but is this the kind of outcome that should change practice? Maybe that's a silly question, but I'm interested to know, do you think this is patient important, and how did you wrestle with that at all when you were designing the trial?
So Ewan, that's a fantastic question that obviously we've thought a lot about. And it's our philosophy with this is that the outcome of a trial probably has to match the intervention and what it does, and that if there's an intervention that is a therapy that's likely to influence long-term patient-centered functional outcomes, that should be the outcome of that trial. I think it would be hard to imagine that a video laryngoscope would impact quality of life at a year, and that there might be reasons to adopt video laryngoscopy from the perspective of clinicians or health systems, even if it doesn't affect patient-centered outcomes over the long term or the short term. So we've wrestled with this a lot obviously in our trials of oxygen saturation targets and other things that we think may affect patient-centered outcomes. We make those the primary outcome. But for trials of devices and things that are key parts and common in clinical care, but are highly unlikely to affect long-term patient-centered outcomes, I think we still have to have a way of knowing which works best. And I think that procedural outcomes probably have that role. And I'll say for anatomic questions in airway management, we use this surrogate outcome of successful intubation on the first attempt. For physiologic interventions, like the fluid bolus trial, we use cardiovascular collapse and cardiac arrest. And for oxygen delivery interventions and ventilation interventions, we use outcomes around hypoxemia and cardiac arrest. So I think that's been our approach, is not to think that we're going to hold every new drug or new device to a bar of long-term patient-centered outcomes, but also want to rigorously evaluate those devices before they're adopted into practice or as they're adopted into practice.
I have a question at the front here.
Thanks. Could you please clarify if the number of intubations done by the operators, were those just emergency room and ICU intubations, or were they all intubations done by the operator?
Yeah, the data we reported on operator experience, the total number of prior intubations were essentially a lifetime experience, so they could be in any setting in the operating room or outside.
So that means that your practice is quite different from, for example, Europe, where someone would get at least a few hundred direct laryngoscopic intubations in the operating room before moving to ICU or emergency room intubations. And if I read your plot in the supplement right, at about 200 intubations, there was not really a clear difference between direct or video laryngoscopy. Is that correct?
So there's no point at which those lines cross with the operator experience in the trial. So there's no point at which they touch or cross. But your point is absolutely correct, that as operators, crew experience, the point estimate for the difference decreases, but so does the probability of first pass success and the opportunity. So this is a little bit like baseline risk of the outcome. The opportunity to improve outcomes is by far the greatest in the least experienced, and is very small in the most experienced. So whether that's an interaction with the video versus laryngoscopy and experience, or whether that's heterogeneity of treatment effect by baseline risk of the primary outcome, I think is tough to sort out. But yes, those new numbers the difference between video and direct laryngoscopy are much smaller among more experienced operators than among less.
I think that's a very important observation, because you can replace experience with a device, but when it's not available, or when it's expensive, or when you're in a setting where it's not as common to use, then maybe it is still important to just send people for 3 months to the operating theater and just train them, before sending them to the sickest patients in the hospital.
I had one other thought, and that's just that going back to analogies, maybe this is sort of like an ultrasound problem. So physical exam's been done for many, many years, very useful for estimating heart filling pressures and things, but I think ultrasound is even more powerful, used as part of the physical exam. So this is an adjunct to your mechanical intubation skills that you develop over time in different settings.
So David, the randomization followed the permuted block model. How did you feel about that in this particular study?
Well, first of all, congratulations. It's great to see another really fast, really pragmatic trial getting an answer to a question in clinical practice. So you mentioned the approach to randomization that was using randomized permuted blocks. It's a very standard approach, and what that will give you is balance between the two arms. And in this case, it was stratified by site, so it's going to give you balance within each site. So the same number of patients in each site getting each of the two interventions. It achieves that by taking groups of patients, so it might be 4 or 6, and within that group, half of the patients get one intervention, half get the other in a random order. Now, the trade-off you're getting there is between the balance that it gives you and the possible risk of losing allocation concealment. So, because if you knew you were looking at a block of 4 patients and the first 2 were to get one intervention, then you would know that the next 2 patients are definitely going to get the other intervention. So we avoid that by varying the block size, which they did in this trial. So by not knowing how large the block is, you don't know how far through a block you are, where you are, and you keep that allocation concealment. So it's a very good and very standard approach to getting balance. However, what I would say is that when we're using any of these stratified designs, these days it would generally be recommended to adjust for stratification in the analysis. And the device trial did include an adjusted analysis. That was their secondary analysis. Personally, I'd have switched that around, or even not done the unadjusted at all. That adjustment for stratifying variables is generally recommended, and adjusting for other baseline factors will also improve precision of estimates, and is generally a good thing to do. So I would have used the adjusted as the primary. One other thought while we're on the statistical matters is to think around clustering. We often think of clustering in the context of cluster randomized trials, where we know that it's absolutely essential to adjust for the clustering, which means essentially that patients within the same cluster have more similar outcomes than patients in different clusters. But where we're looking at this type of trial, where the intervention is delivered by an operator, and the outcome here particularly likely to be associated with that operator's skill and experience, you will still have that clustering existing. So 2 patients who have their intubations by the same operator are more likely to have similar outcomes than 2 patients who have intubations by different operators. So it would be good to see clustering by operator accounted for within the statistical model.
And you clearly closely read the supplement. We do that in the supplement. Although the operators only included an average of 2 patients, so the clustering was really small, but we did it anyway, and it's there. I love that you've summarized in 2 minutes what it took us years to put together. Yeah, it's all exactly right.
So, Caroline, you're working in the pre-hospital world. What's your go-to when you're out in the field?
So there are a number of UK air ambulance services that are using video laryngoscopy now. We've got to remember that pre-hospital setting is very different to the emergency department. There are environmental considerations for the equipment working. One of them being that I tend to drop the bag in streams or rivers quite a bit. So my DL works perfectly after that, but perhaps not my VL. But I suspect, I know a lot of the previous studies on pre-hospital VL versus DL don't do well, the VL doesn't do well, but I wonder if you ask a pre-hospital practitioner who's used to using VL and that's their go-to preference, that will probably succeed. If it's someone like me who's grown up on DL and I don't intubate every day in my day job, I'm probably going to do better on DL today. So I suspect that's one of the considerations when we're looking at these studies.
Well, a high majority of patients intubated in this trial were ED practitioners. It was nearly 70%. It'd probably be not similar in the UK or in ED.
Yeah, so I think looking at the cohort of airway operators in this study, they were fairly junior to be intubating some of our most difficult patients. So that's obviously, we have to consider the generalizability of that to our practice. But certainly in the US, emergency physicians are the intubators. It is a skill for UK emergency physicians, but we tend to leave it to the anaesthetist or intensivist. When we're dealing with a critically ill patient, the emergency physician's leading a resuscitation, and the airway operator is often an anaesthetist or intensivist in UK practice.
So we touched a little bit already on capnography and the use of, so capnography is not just for CO2, it's also, we can look at the end-tidal oxygen. Fiona, Alistair, the Difficult Airway Society guidelines for the critically ill patient mention a target for end-tidal oxygen before intubation. What are your feelings on
end-tidal oxygen before intubation, being greater than 80, is that what you mean? Yes. So that's really useful, isn't it, actually? I think it's a standard of care, but I'm interested in what you said about waveform capnography, because it is, I think, we use it for everyone in the UK, and it's a simple measure that would be worth looking at.
This is fascinating to me. So we don't have end-tidal oxygen levels available. I've never seen that done, and we don't have waveform capnography standard in almost any of the hospitals in our system. And so I think I'm going to have to go home and do some reading and wonder whether we should be implementing this or whether there's some equipoise around this, because these are a huge difference in practice setting. So do you all use end-tidal oxygen levels in clinical practice?
In operating theatres.
Yeah, mainly in the operating room because the technology's there.
But
waveform capnography would be in ED.
Yeah.
On the back of the NAP4 study where remote areas, there's a higher incidence.
And we use it in the context of cardiac arrest monitoring and that sort of thing, but not for intubation.
And Matt, we've taken it one step forward further than that. So we've now been doing a 2-person verbal intubation check, just looking to avoid unrecognised esophageal intubations. So I was in theatre yesterday and looking with my anaesthetic assistant, confirming we couldn't all see the tracheal tube passing through the cords on the video laryngoscope screen, and then together, both looking at the screen and making sure we can see 7 capnography waveforms. And it's really good for flattening the hierarchy, really good for teamwork. There are a number of the cases of unrecognised esophageal intubation, the big airway cases that Ellen was talking about, where one member of the team said, it's a cardiac arrest, I think the tube's in the wrong place, and the intubator said, no, I'm sure it's grade 1 view, but in fact, it turned out that member of the team was correct. So we're trying to address that and include the team in the intubation process. So a number of reasons to look at it.
So, super study. Oh, shit.
Super study, yeah.
Is that going to work now?
Yeah.
Yeah, sorry, super study. Will I just?
Yeah,
That's
sure.
perfect. Super study. A few things. I was just, a few things. It just shows that trials that for ubiquitous interventions in the hospital or acute care setting, it's super. I think we should be doing more of these. In my practice, we use video laryngoscopy all the time. I wouldn't have used direct laryngoscopy for at least the last 5 years. And it's just really interesting, the different healthcare systems. I think our most junior intensive care resident would have, over 95% would be anaesthetists that have well over 1,000 intubations under their belt. And that's the most junior. Most of them would be much more than that. And and the other thing is when you've got an open label trial where the observer's not blinded as well, there's always worries about bias, because I think most people think video laryngoscopy is really good. They like it. I use it. It's a super teaching tool. I think everyone sort of said that. And would I be a devil's advocate by saying that would your primary outcome be that video laryngoscopy is superior to direct laryngoscopy with a very novice operator supervised by a senior clinician? Because I mean that has got the master, the Jedi driving the junior, you know what I mean, in a sense, because you can do that easier with the scope. And I think that's why we all use, video laryngoscopy.
So I think there's several pieces to that question that we can talk about. So the piece we don't have the ability to address is what is the role of the supervisor, because all of these innovations had a second physician present. And so we have no contrast. I think it's absolutely true that your ability as an attending physician to provide feedback during direct laryngoscopy is limited, and it may be that coaching or real-time feedback is an important aspect of what makes video laryngoscopy beneficial. Yeah. We don't have any ability to inform that. Yeah. The second piece of it is really is key. That is the idea of for which operators is this the most beneficial. And I'd just say that the prior trials of video laryngoscopy versus direct laryngoscopy have not collected any information on operator experience. So we went into this trial thinking this is going to be a key aspect of this, and we collected not only their overall intubating experience, but their experience with each device, which I think is really important. If you've done 1,000 intubations, all of which are with a direct laryngoscope, that's probably very different in terms of how it modifies the effect of VL versus DL. So I think the area, and we have a lot of certainty with novice intubators, and in that 100 to 250 range, the effect is still more than what we went out looking for in favor of VL. So I think in that range we have modest certainty or some degree of certainty, and I think above 250 intubations of critically ill patients, this trial doesn't have as much information, and so the question is, would the answer be different there, and if so, why? Would you add to that?
Yeah, just to address the point about the independent observer, because that's a very good point. We have ED sites in our network, including mine, that routinely have video recording of resuscitations and in our resuscitation bay. So for QA purposes, we can go back and review cases. And so as part of this trial and the Bougie trial previously, in an informal way, we've gone back and looked at that, and our independent observers perform very well in recording the primary outcome compared to our essentially prospective video review of those cases. So I believe it's recorded robustly. And then I wonder if we're moving the science in this field more and more towards bundled care with emergency airway management. And so perhaps there's a bundle of equipment if you have access to this and you're in a hospital or a country that does, your first attempt should involve a video laryngoscope no matter how much experience you have. It should involve waveform capnography to confirm your tube, and the PUMA guidelines and the publications in all of our journals that have been copied that forward have been great. So that's something we'd really like to study, maybe in a cluster randomized fashion.
Can I ask then, just on that basis, and I might have missed it and I apologize if it did, in some healthcare systems where the intubators won't be, expert anesthetists, they actually do have intubation checklists for all, and like for direct laryngoscopy, positioning the head is really, really important for success rate. And those are included. Did all of the hospitals or some of the hospitals use such checklists, do you know?
This is getting into old territory for us, old wounds. We did a randomized trial in these sites of a checklist versus none that didn't have any benefit, so we did not mandate the use of a checklist in these sites. However, many of the sites have their own institutional checklists for tracheal intubation, and so checklists that are catered to each institution are present at a lot of the sites, but we did not standardize it based on that prior work.
Mm-hmm. And just like the waveform capnography were recorded in those supplementary tables, we have each site identifying whether they routinely use a checklist or not. It was the majority that do.
Yeah, perfect, thank you.
Yeah.
Katrina, I've got a quick question, if that's all right, to ask the Mats about the independent observer, because I think it's fantastic you had that. Did you say that you had them available 24 hours a day? Did I hear you say that? Yes. Okay, that's amazing. And did you collect any data looking at intubation success rates, depending on the time of day, whether it's 3 o'clock in the morning or 8 o'clock in the morning on a Monday?
To answer that, yes, but we haven't known what to do with it yet.
Okay.
So we have the date and time to the second of every intubation, but we have not yet performed any analyses around that. So your suggestion is that maybe nights and weekends, you may have less experienced operators, less coverage, and you might worry that outcomes might be worse overall, or there might be more opportunity to benefit from an effective intervention.
Just interested.
And we should look that up.
Okay.
And I'd say an interesting thing about perhaps U.S. emergency medicine practice is that a lot of the physicians that really like to do critical care and have those cases to themselves choose to work at night. So some of our most experienced faculty airway managers do the night shift. So it'd be interesting to see what we see and if there are differences in our settings.
Can I ask you a little bit about the hyperangulated VL? I run a fellowship program and they're doing advanced skills, so teaching in the hyperangulated VL technique. It's completely different. It's a much more difficult technical intubation. View is beautiful, but actually deploying the tube is a problem. And as I say, even with my airway fellows who are CCST, they're qualified, they've done thousands of intubations, they struggle with it. They struggle with the stillets and so forth. But we do train them. But did you see any difference? I know only about 14% in your study used hyperangulated VLs, but I think, is there a caveat there? Or can you sub-analyze that and see what the deployment or the first pass success was?
We're looking knowingly at this. We think this is a really important unanswered question, that if a video laryngoscope is best, is it the standard geometry blade or is it the hyperangulated blade, because they work very differently. I'll say that in our trial, we did also have the operator pre-specify that if they were randomized to the video group, which would they use? So we have a baseline, a subgroup, and the effect estimate for video versus direct laryngoscope among those who would have used a hyperangulated blade, video versus direct among those who would have used a standard geometry, was similar in this trial. But we think this is another trial, that this is, and I would say we just surveyed all of the sites that participated in this trial, and about a third predominantly used hyperangulated, about a third predominantly used standard geometry, and about a third used a mix of both. And so we think that question needs to be answered.
Great. Hope you can do it for next year.
So we've been talking about NAP4, and from NAP4 we have to have an intubation plan for unanticipated extubation in the intensive care unit. You used Cormac-Lehane grading for the video laryngoscope as well as DL. Is that common practice? Usually I would just say good view, great, the view on a video laryngoscope is different, and you can get a great view, but it can still be tricky to get a tube in. Why did you use it for both groups, the Cormac and Lehane grading?
We chose the grading system kind of for its familiarity in our research network. People can look at those 4 images and reliably choose the one that corresponds to the grade they got. But it's a great point that I don't really understand how the Cormack-Lehane grading system, even if you go to a modified system where you subgroup into 2A and 2B and those things, how that performs when you're holding a video laryngoscope compared to direct laryngoscope. That's an important question. We've looked at that with some post hoc observational analysis of previous trials we've done, and we began to unpack it in the device trial. And so we hope to have more information on that. But I think an important finding in the device trial is that video laryngoscopy, not surprisingly, improved the grade of view. But in the operators of this trial, it also made it easier to pass the tube on the first attempt. And so that's another argument for using it in a more universal fashion.
I'd hit that even harder. So Prekker's being modest. He did the work in Annals of Emergency Medicine in preparation for this trial that split airway management into its two halves, so laryngoscopy and tracheal intubation, and looked observationally first, and now within the device trial, how does VL affect laryngoscopy? How does it affect tracheal intubation? And I'm a direct laryngoscopy person. I was very skeptical of a lot of this, so I said it's going to make it easier to see the cords and it's going to make it harder to intubate. And in the observational research and now in device, I was wrong about both that. It makes it easier to see the cords, and in at least those two studies makes it easier to intubate.
And it may be the stiletto and the bougie as well. I mean, we wouldn't in UK routinely use stilettos. We would use bougies. We're bougie people, but huge experience of that, because with the stiletto you still have the bulky tube going in. So with the bougie, but it's interesting that you found that high success.
Any questions on Twitter, Chris?
Hello. Yeah. First of all, the New England Journal tweet of your trial has passed 25,000 views already.
Wow. You did it.
So, you know. So it's getting out there. I think we've covered an awful lot of the stuff that has come up on Twitter. I suppose maybe one thing that I might ask about is the role of an intubating assistant. So in the UK here we have ODPs who assist us with tubes, with the shape of the bougie, etc. And did you look at who was assisting the intubator?
Yeah, that's a really important role. I think the operator has a lot on their mind trying to focus on performing that procedure well. And so in the US, the respiratory therapist often fills that role. And so they're, supervising oxygenation and ventilation of the patient, but also will be the assistant in that extra set of hands. And so the choreography of that procedure needs to be a really tight one, I think, to appreciate the best results.